Part of the talk here, though, is to have some objectives, and my objectives are fairly straightforward. Basically, understand robotic surgery, understand what the watch and wait approach is for rectal cancer, and understand what the current data suggests regarding neoadjuvant therapy for rectal cancer. So this is just a little bit about me, since I don't know most of you. I am a board certified in colon and rectal surgery as well as general surgery. I enjoy everything about Utah and everything that exists outside. My dog does as well, and she also enjoys fetching. As you can see, I found all those under the couch a couple weeks ago. So I am board certified in general surgery and board certified in colorectal surgery. I've been in practice for 20 years. I have extensive experience in all aspects of colorectal surgery. My passion and my interest really is minimally invasive surgery, and so I try to apply that to all surgery that I do. What is colorectal surgery? Just a review. It's a specialization in surgical management of colon and rectal care. Includes anorectal disease. It's an additional year fellowship after general surgery, so you need to complete 5 years of general surgery followed by a year of colorectal surgery, which is basically dedicated to colorectal surgery. Does have its own board certification, both oral and written examinations. The scope of the practice is really colon and rectal cancers, inflammatory bowel disease, Crohn's and ulcerative colitis, diverticulitis, other benign disease, rectal prolapse, and anorectal diseases. So since the topic is what's new in my specialty, I thought that I would start with where we are, and then I have a next set of slides that talk about what's on the horizon, and then lastly, what's in the future, what kind of weird stuff is out there that we maybe will see in the next 10 years, or maybe not. So to start with hemorrhoids, this is bane of everybody's existence. I just wanted to talk a little bit about the anatomy. So there's internal and external hemorrhoids. Everybody has them unless you've had them surgically removed. They're a normal part of our anatomy. They help cushion when we have bowel movements, protect the area. It's when they become abnormal that they start to fall down, prolapse, become enlarged, that they become problematic. The treatment, I've kind of broke this slide down into two approaches. One is sort of, I termed it intermediate, but it also means sort of office, sort of non-invasive type approach. And those are hemorrhoid banding, which is probably a lot of people are familiar with. We can do in the office. Really only for small internal hemorrhoids that you can do that for. It's not designed if they have any sort of external component or really anything greater than a grade 2 in nature. Hemorrhoid energy therapy, HET, is another procedure that's usually done in the GI suite. Basically, you heat and seal the hemorrhoids similar to the rubber band, but you do it more circumferentially. It seems to be a little bit more effective than banding. And sclerotherapy and cold therapy, some of the other things that people read about but are not available in the United States. All have about the same efficacy and all are used for early onset hemorrhoids. A surgical approach, so the old-fashioned hemorrhoidectomy, Ferguson hemorrhoidectomy, where basically we excise the hemorrhoid complex and sew it back up, has all the horror stories that everybody talks about, pain, discomfort, but is ultimately very effective and works almost 100% of the time to solve the issue. THD, which is some progress in trying to alleviate some of the pain. This really works well for internal hemorrhoids, not so well for external hemorrhoids. Requires taking to the operating room, using an anoscope and an ultrasound and identifying where the vessels are. I'm going to try to use this without wrecking it. So identifying where the vessels are and then basically tying those off to prevent any further blood flow to the area and causing the hemorrhoids to shrink. PPH, which is for prolapsing hemorrhoids, it's the stapled hemorrhoidectomy. By and large, the Colorectal Society has gone away from that approach for various reasons, but I won't get into that, I guess. Anal fissures, which is another thing I see very common. Probably all you see these in your office if you're primary care physicians. This is pain, so they have pain with bowel movements. It's caused by a tear in the anoderm, just below the dentate line. They usually have a small amount of bleeding. Can be confused with hemorrhoids, is it on the right there. Whoops. Let me go back one more. On the right, you have this sentinel pile. It's basically just an inflammatory reaction that creates a tag that looks like hemorrhoids. The treatment really is conservative initially, fibered, followed by nitroglycerin cream or calcium channel blockers. This causes the internal sphincter muscle to relax and allow that area to heal. And lastly, if those are all fail, we can move to other more invasive techniques such as Botox or sphincterotomy. My algorithm is usually nitroglycerin cream, calcium channel blockers. If this is unsuccessful in males, I go right to sphincterotomy. The risk of incontinence is significantly less. In females, especially of childbearing years or ones that have had delivered, then I go to Botox first because it's reversible and they have less opportunity to have incontinence associated with it. Abscesses and perianal fistulas. So the fistula is just a progression of abscess. You can see on the right, an abscess is, what it does is it's a connection from inside. So everybody has glands here that secrete mucus, again, a normal part of our body. It helps protect this area. When these glands get blocked up for whatever reason, which is the million-dollar question, why did this happen to me? We don't really know. When this happens, it creates an abscess, and that abscess looks for the easiest way out, which is usually to the skin. And so by definition, you now have a connection from outside to inside, which is a fistula. Most of the time when we drain these abscesses, you can drain them in the office, in the operating room. If you look at the literature, it's somewhere in the 40 to 50% of these will resolve on their own, and that'll be the end of it, and 40 to 50% will develop into a fistula, which will require further surgery. If a fistula does develop, my normal approach is to take them back to the operating room, open the abscess cavity, and do what we call a seton, which is a string, some sort of mechanism to allow the infection to drain and basically to isolate to a single tract. Has the highest success rate of being able to close the fistula ultimately. The best procedure to close the fistula tract is a mucosal advancement flap. I like to tell patients like a tire flap or a tire patch. Basically, we close this hole here and we raise some tissue off the underlying mucosa and advance it over the top, just like you would do if you were going to patch a tire. Most patients seem to understand that. And it works about 85% of the time, which is the best results that we have. Another area of interest is diverticulitis. This has been interesting to me in my 20 years of practice, and probably all of you that have been in practice for some time. When I first started in residency, we almost looked for an excuse to operate on these people. If they were admitted to the hospital, they had diverticulitis, they needed surgery. If they were 30 years old, they needed surgery. If they had diabetics, they needed surgery. If they were on steroids, they needed surgery. And over my career in the last 20 years, we've done everything in our power to not operate on these people. It seems in fact, people that are admitted to the hospital with abscesses and drains, we are not operating on. Well, the American College of Colorectal Society has looked back at all the literature and created some new recommendations that came out last year, which is basically gone back almost to what we were 20 years ago, which is, I guess, the way medicine works. And so these are available if anybody wants to look them up at the society guidelines. But the long and short of it is elective surgical resection is recommended after recovery of complicated diverticulitis. So patients that are admitted to the hospital with diverticulitis that have a phlegmon, an abscess, some sort of fistulization to the vagina or to the bladder or even to other parts of the bowel would all be candidates for surgery, and this is all level 1 evidence, so it's not speculative. The next bullet item is elective resection is not recommended based on age, so as I kind of alluded to early, the younger, just if you have an episode of somebody that's 35 years old in your office, that doesn't necessarily mean they need surgery. Elective resection for non-complicated diverticular disease is individualized, and I think that's really they had a hard time ferreting some of that out. Some of that is related to the timing of the non-complicated diverticulitis. We all see people that come to our office and have diverticulitis, and then they have another episode 6 months later and another episode 6 months later. Those are the people that you would consider for surgical resection. Cancer, so the state of affairs in cancer should be that it's a multidisciplinary approach, which means that we have all the ISTs and some other people involved, nurse navigators, nutritionists, and approach it as a team approach to deal with cancer. We're basically removing the silos. No, there's not individual treatment. You're not seeing one patient in the office and following up with somebody else and not really understanding the full progression of the disease process. We should follow the standardized recommendations of the National Comprehensive Cancer Network. There's several very straightforward recommendations on how to follow it. This is recommended by the Commission on Cancer. There's also national accreditation programs for rectal cancer, which is a separate accreditation. We're dealing specifically with cancer of the rectum and how this should be approached because it is more complicated than colon cancer. Basically, it means that there's a conference, so we present each patient, all these people are involved, we discuss the care, and this should be done so at every critical point of the patient's progression of the disease process. And this should also make sure that we include in the loop the primary care physicians. And this does result in better outcomes in patient care, has been documented and studied. So this is the area of interest for me. How we can apply robotics to colorectal cancer. And this slide sort of demonstrates, again, actually my career. When I started, we did everything open, big incisions, and we were just starting to do laparoscopy, and that was about the time frame when laparoscopic colon surgery was put on a moratorium for concern that it was actually bad and making patients or outcomes worse and causing more problems, and ultimately that was dispelled. So as you can see, big, large incisions, long hospital stays, lots of pain, still the gold standard if you need to go to it, but time has progressed and we're now doing laparoscopic surgery and then ultimately even robotic surgery, and I'll talk a little bit about the benefits of robotic surgery. As you look at the data, approximately 5 years ago, it was somewhere in the 85% of people getting colon surgery were still in this category, believe it or not. The last number I saw was it was trending down. It's somewhere in the 60 to 65% have moved to this, but we still are not over here yet. So we actually have a long way to go, which is quite interesting to me, having seen the progression over 20 years. Just a schematic that kind of depicts of what laparoscopic or robotic surgery, how that looks differently than open surgery. Small incisions, 1, 2, 3, 4. There's some multiple variations of that versus one big incision. So this is some of the benefits, 3 to 5 small incisions. The surgeon does control every movement of the instrument, so that's one thing that I have not really, or I've paid more attention to with patients and telling them, it's like, no, we control it. Because I think when you tell them robotics, they think, oh my gosh, somebody's going to come in here and the robot is going to take over. We control everything. It offers us benefit. It allows us to see better, 3D vision. We can actually see in 3D, which is a huge advantage to surgeons, as you can imagine. We have wristed mobility, allowing our wrist to work with our instruments, which is not the case with laparoscopic surgery. So laparoscopic surgery is like working with a 2x4. Everything is straight and fixed. Robotic surgery allows the instruments to go in and move just like you would with your wrist. So it's combining the benefits of open with a minimally invasive approach. Again, just more pictures depicting. This is kind of the setup, what it looks like in the operating room for anybody who's not familiar with this. This is where the surgeon sits. The tables here, there are people by the patient. These are the instruments that come in. And then there's what they call a tower, which basically has all the controls for the laparoscopic equipment. One additional benefit, in addition to being able to see, is that we can inject ICG, which helps us identify where the blood flow is, which greatly reduces the amount of anastomotic leaks and potential complications associated with colon surgery. And you can kind of see what this slide is depicting is that this is where the bowel was supposed to be divided when they gave the dye. You could see that this is where they had marked, but this is all dead. So this would have been probably a failure of anastomosis if you had gone ahead with that. This is just a random case of mine. This is just, and it is a random case. I always hate when people put their best cases up there to make them look great. This is I just pulled one of the cases that we have. It's a right hemicolectomy that I did. And it was, I don't know, back in June. And it took me 100 minutes, which is, somewhere in the hour and a half range. In general, like on the easy ones, it's probably under an hour, which would be about what most of the time it is for open or laparoscopic surgery. And even this says, I didn't know this, but I just saw this last night, that this was a bigger patient, which always makes things somewhat difficult, but there are advantages with the robot with the bigger patients. And so that's just kind of a depiction of what happened. And you can see the specimen wasn't cheated. This is the terminal ileum and the transverse colon, so we've taken the entire right colon and the mesentery associated with it. This is, again, just my data, and it's been added to, but this is from a few years back. But this is looking at my data compared to length of stay, or length of stay conversions and readmissions compared to national data. This big green bar is open surgery. This is laparoscopic surgery, and then this is with robotic surgery. So you can see a significant difference, and these numbers are fairly accurate. If you look at the literature over and over, it's probably more like 8 than 9, so this is a little bit fudged probably, but the most repeatable number for open colon surgery is around 8 days. It's about 6 days for laparoscopic surgery, and mine is somewhere in the 2 days range. And I've become even maybe a little more aggressive at sending them home, so it may even be trending down for length of stay. And you can see that for the hospital administrators that's a significant cost savings, and you could see why they would want to move towards that. So having said that's where we're at, what's on the horizon and what kind of things can we think about moving forward and what's new? There's not a lot in anal rectal, a lot of hopefully energy devices and devices that can somehow reduce pain control. I think one of the biggest advances, which the hospitals don't allow most of the time, is Expero, which is the long-term anesthetic in hemorrhoid surgery. That's what it was approved for. That seems to work the best and has the best pain control for a couple of days for patients, but it is somewhat expensive, and so hospitals are reluctant to buy it. Benign disease, so diverticulitis, again, continued movement towards minimally invasive techniques and robotics, as we talked about. There's still a significant amount of surgery being done open, which can certainly be done minimally invasive. There is a trend, it's sort of quieted down, it seems, a little bit, about removing organs through the natural orifice, through the mouth, or through the anus. Having said that, the Colorectal Society is moving forward with some transanal total mesorectal excisions, which is basically doing a rectal cancer surgery through the anus with the robot. And so a few centers are doing that, but it's certainly not widespread, but it may be something that kind of comes to a town near you, I guess, eventually. And then another very interesting thing, and I sort of alluded to it on the last slide, is moving towards outpatient surgery with close follow-up for major surgeries. Some centers, like Mayo Clinic, have talked about it, and I think they even have instituted same-day surgery for certain patients, such as right colons or sigmoid colon surgery, which goes fine, and they have a low risk profile for the patients. And I certainly could see how we could do that. We lots of times admit the patients overnight, and I see them the next day, and they're sitting there fully clothed, and they're wondering why they're in the hospital. And I think that makes a lot of sense. I think there certainly should be a move towards that. It's going to have to be measured, certainly. Colorectal cancer, so I was just at the colorectal meeting actually a couple of weeks ago, the national meeting, and there were a couple of interesting topics. The first one was a concept of total mesocolon resection, which is basically what we do, but it was emphasizing the importance of that. Again, sort of a full circle thing, the thought that lymph node involvement meant that they had systemic disease, and therefore it didn't really matter, you were going to get chemotherapy anyways. But what we're seeing is that if you are removing all the obvious lymph nodes and the lymph nodes that are draining from that area, you're having a better outcome. The data is still a little bit wishy-washy on that, but I think it's going to probably tend towards that. The next two bullet points, I actually have two additional slides on this. I think it's actually quite interesting, but it's on neoadjuvant therapy and watch and wait approach to rectal cancer. The bottom is about training, and again, I think this is interesting because all the societies are pushing all the new graduates and even the people of the society to become leaders of their hospitals and organizations, which currently was not the case when I went through residency, and there's been a big push for medical students and for members of the society. There's weekend lectures, there's conferences and all these sorts of things that are available to people to be leaders in their society and in medicine. There's a lot of education models that we have now. So, for example, in rectal cancer, if you're going to be doing rectal cancers, there's education models that have been are starting to be formulated for everybody involved, including the pathologist and the radiologist and the surgeon, to make sure that we're doing an adequate job and we're doing what we need to be doing to make sure that the patients get the best outcomes. Okay, so this is the slide on total neoadjuvant therapy. And this is just straight out of the NCCN guidelines. And this is for patients that are candidates, so T3 and any end disease that would undergo neoadjuvant therapy. The preferred approach is getting all their chemotherapy and radiation before having surgery. And the reason is that they have a much better complete clinical response. The disease-free survival and the overall survival is improved compared to the other approaches such as the neoadjuvant therapy. And so just kind of to clarify for some of us that have been around for a while, this is what we used to do. So we used neoadjuvant therapy, so they used to get chemotherapy and radiation for 6 weeks, have a little rest period, be reevaluated, undergo surgery, and then get the remainder of their chemotherapy, so the last 4.5 months of chemotherapy. Now what's happening is, or what should be happening, certainly the preferred method, is that you get your chemotherapy and radiation, get all of it up front, and then you have surgery. And the reason being is that they've seen that every 4 weeks that you wait on chemotherapy, you have a decreased percentage in overall survival. So chemotherapy is significantly important here. To sort of add to this and give it one more layer, the current work is to look at should you give the chemotherapy and radiation or give the chemotherapy first? And is there a difference? Depending on what sort of order we do for the total neoadjuvant therapy. And as the literature sort of is evolving, the thought is that the chemotherapy and radiation followed by chemotherapy is probably going to win out. And so we may see in future versions of the NCCN guidelines that this will switch. It'll go over to this approach and become the preferred approach. Because of all of that, we've seen, as I said, complete clinical responders or pathologic responses gone away, so the disease is almost gone. So there's been this development of what we call watch and wait. And basically it means that there's no surgical intervention. So we just do the total neoadjuvant therapy, and then that's it, and we just continue to watch, and people are not subjected to the morbidity associated with rectal cancer surgery. And so there needs to be no evidence of don't want to give that away. No evidence of the disease. We need to evaluate this with biopsies, MRI, and endoscopic evaluation to ensure that there's no evidence of disease left. And this is largely because we're seeing an increase in the total neoadjuvant therapy approach. And again, the disease-free survival and overall survival is slightly lower in the watch and wait group, meaning it's not significant yet, but if you look overall at all the studies, it's maybe 1 or 2% lower, so there is some risk of watch and wait. Lastly, there are some reports that it may be more aggressive in some cases where the cancer may come back with more metastatic, maybe in the lungs, if you watch and wait. And there are other reports where say there's no difference and the cancer just comes back locally as though it was at the same stage prior. So I think that the jury's still out on that. Okay, the last interesting stuff, the future. And this is have 4 separate areas of interest here. And one is artificial intelligence colonoscopy. And so what this is they're actually at Harvard they're developing an algorithm to identify polyps that we don't see as proceduralists, that we miss or can't see. And it's based on previous experience, endoscopic, light features, and all various things. And what it'll do is it'll put a box on the screen and show you where the polyp is or the area of concern. And it continues to sort of become smarter and progress. I think this is something we may see in the future, maybe more near future than farther away. Another sort of interesting thing, which maybe, I'm not sure how this is all going to pan out because we don't have a lot of anastomotic leaks, but there is this look at when somebody has surgery and has an anastomotic leak, that usually means that they need more surgery, potentially take down their anastomosis, a fair amount of morbidity associated with it. Several papers are looking at endoluminal wound vac, so the wound vac like we put on our abdomen can be placed with a colonoscope in the cavity, which is sort of demonstrated here. This is where they've got a leak abscess cavity, and they put this wound and it allows it to suck it down and seal. After about 12 to 16 weeks, they see significant improvement. One last side, and I think this is probably the most interesting, but the most scary for me is microbots. And this is a true article. It's about little microbots with artificial intelligence that are sent into the colon and designed to find an area and biopsy it. And so where does one go with that? That's the scary part. Can there be hundreds of these things dropped in through a small laparoscopic port that would go and resect part of your colon? Can they eat up the cancer? Can we? Who knows? So this is where things are going, and I think we'll see some interesting stuff related to that. The last one is wearable technology. A big talk at the conference was about wearable technology, and now everybody has a watch that measures their heart rate and their blood pressure, and they're telling them to breathe and relax and everything. But they're actually taking some of that data and some of that technology and now applying it to surgeons and putting sensors on their gloves, putting EEGs with the headband, putting heart rate monitors, and watching how they're sort of working and gathering data and using it to train other surgeons. And there's the limited data they have now is incredible. I mean, it really shows what we think, what we know, but I think it's going to allow the teaching surgeons to say, look, here's where you're wasting energy. Like, you know, use it, do it this way, and you can actually be objectively be able to see how you can improve surgery. And so that's sort of an interesting area. Hopefully I've completed the objectives and be happy to take any questions.
Thank you, Dr. Baker. We have a question. Is that, or are you
Yes,
adjusting
it was
the
an excellent presentation, thank you. Would you speak to the issue of younger age presentations for colon cancer that's being observed today?
Yeah, definitely there's a trend for younger age, and I think some of the guidelines for screening has changed to 45. Some of that is that they've developed these guidelines. I think the American Cancer Society and then also the U.S. Task Force are two separate societies that are 5 years apart, and so I think we're going to see the complete recommendation move forward to 45. I don't know that we have a great understanding of why we're seeing younger and younger and younger people. Clearly it has to be environmental. You wouldn't see younger and younger people just over a short period of time. That's a genetic component. It has to be some sort of environmental, probably the McDonald's we're eating.